Thank you all for coming to this talk. This is, excuse me, the first time that this kind of body of work on the UCAS project has sort of been presented kind of together all at once. So I'm really excited to kind of unveil the results of many, many years of hard work by a great team on this project. So our goal here, is to really talk about how to understand what's actually happening in the world of practice. And I'm going to continually, perhaps I'm going to beat it into the ground, use the metaphor of building a bridge, right? Because if we're going to build a bridge between research and practice, you have to first survey the landscape to know where to put that bridge. And I'm going to say that a lot. And the goal here really, my hope is to provide information on what providers and clinicians across disciplines in various areas of the United States are doing, and then highlight some gaps so that we have a kind of guidance for how to go forward and how to work together most effectively. And I'm really proud to be here presenting on behalf of the UCAS consortium team. So the PIs, the other PIs of UCAS, again, there are myself, as well as Dr. Elizabeth Cohn, who's the Associate Provost for Research and the Rudin Professor of Nursing at Hunter College, Dr. Amy Drahota, who's an Assistant Professor at Michigan State University, Dr. Connor Kearns, who's Associate Professor at University of British Columbia, Dr. Lauren Moskowitz, who's Associate Professor at St. John's University, Ali Weiner, who's an Assistant Professor at Rush University, and Lata Surya, who is an Associate Professor and Director of the Arts Center at Rush University, and is also a Spark site PI as well. We also want to thank Dr. Neil Chaco, who was very instrumental in helping us put this project together up front. This project was funded primarily by the Pershing Charitable Trust, as well as by the Delphi University Center for Health Innovation and the Brian Wright Memorial Autism Fund. And we had effort funding for several of us involved in the project from NIH, as well as the Simons Foundation. So, kind of stepping real broadly, as hopefully everyone on this webinar, is aware, folks on the spectrum are known to have high service needs. This is true in childhood as well as across the lifespan. And in fact, addressing service needs is one of the top priorities of both autistic self-advocate groups, the NIH, clinicians, researchers. It's one of the few things that we agree on. But of course, who do we ask about what those needs are and how to address them, right? We can agree that there are needs out there to be met, but not much agreement, and actually not even much discussion often about what specifically is being addressed and what are people doing to address those needs. And in fact, those disparities are augmented by the fact that there's really a uniquely wide range of providers and disciplines that serve and support autistic individuals and their families. The convergence of needs is so great that our federal agencies like the Health Resources and Services Administration have whole units and programs under AUCD, including things like the LEND centers throughout the country that are simply just about getting those disciplines to work effectively together. Well, then, if that's the case, then how in the world do we even begin to address questions like evidence-based practices, right? Because evidence-based practices for what, for whom, done by whom, with whom are incredibly complicated. And importantly, in the world, people are doing lots of different things to try to help folks on the spectrum. Some of them are evidence-based, some of them are not. And if we ethically, as clinical scientists, care about creating practices that we believe have evidence for their effectiveness, that they help something that is of concern to somebody, we need to actually know what folks are doing in the world, and we need to actually build a bridge. And what I mean is a bridge between what the practices, evidence-based practices are, on the one hand, that we would like to have, hopefully have more people doing, and what folks are actually doing in the real world. so that we can know where to put that bridge. Again, like I said, I'm going to beat this metaphor into the ground, but I think it's really important, right? If you're going to try to cross a river, right? You don't just find any old point on the river and say, let's put a bridge here. You try to say, either maybe you want to find a particularly narrow point or a particular point with particularly sturdy sides, right? All of these things are true when we're trying to think about bridging research to practice, as well as bridging evidence-supported interventions out into the community. And the result of this is, what's called the treatment access gap. And essentially what this means is that, there are interventions, there are approaches to support folks on the spectrum that meet the needs of those folks in many cases, not all cases, but, there's a really deep and active, both empirical and clinical universe where these things are being done. But we're not getting those treatments to the people who need them. Sometimes it's because folks live in places where there's almost nothing at all, and some of you might live in some of those areas, but in other cases, folks either don't have knowledge or access to the particular interventions that might most help that in a given individual at a given time. So how do we build a bridge, right? How do you go about actually, connecting the treatments to the community to build that access? Well, once again, butchering this metaphor, we have to survey the landscape, right? You have to look at what's out there on either side of that river, of that chasm, of that gap, and say, all right, what are people actually doing out there? Are there folks, for instance, who are already doing practices that we are trying to disseminate? If they are, fantastic, we should support that. If there are folks who are not out there doing those practices, but instead are doing something else, maybe that's a good place for psychoeducation. Or perhaps what we need to be doing is listening to those practitioners. And if they tell us, hey, look, here's a thing that you researchers haven't studied much, but we understand to be really valuable and is meritorious and important, and we've used it for years, then we as researchers also then need to be humble and say, well, let's go ahead and look at that and try to understand where that's coming from, rather than just assuming that our job is to run around with hammers looking for nails. So folks have, of course, tried to do this already, right? And there have been a number of really nice previous, sometimes a little bit smaller studies that have started to look at what are practitioners actually doing in the real world as a way to facilitate dissemination of intervention practices. But these previous studies have often had limited sample sizes. They're representing fairly small groups. They've often represented a limited range of disciplines or just sampled one geographic region. And really, you really kind of need all of these things. You need a large sample across, many of the disciplines, or even all of the disciplines that work with folks in the spectrum across geographic regions, to really begin to get a sense of what's happening out there. So no previous study then to date has looked across all disciplines across multiple sites nationally, particularly looking at the school and teenage population. And I haven't said as much about that to date, but often many of the dissemination implementation studies and projects that have existed have focused more on early intervention and very young kids. But of course, young kids grow up, and many of us who work in this field, primarily focus on school or teenage individuals who are still entitled under IDEA to access services, and so are potentially in a position to benefit the most from greater alignment across the treatment access gap. And then, of course, also the question is helping what? So often these previous studies have focused on one particular area, like behavioral concerns or learning functional skills. What we did is we were looking at the kind of three core referral questions when we as clinicians get referrals for folks who need help. The three main things that school and teenage kids are often coming with on the spectrum that their families are often seeking help with, and those domains are social, so social competence or connection, sometimes called social skills, anxiety, and particularly anxiety around engaging in things that they maybe need to for school or or in the community or at home, and then externalizing or aggressive behaviors that might present safety concerns. And so this led us to then embark upon the UCAS, or the Usual Care Autism Survey study. The first paper that kind of lays this out came out a few years ago, where we used what's called kind of just to describe what we would call a community engaged participatory research method, or CEPR. Because the idea of this is to say, how do we listen? We need to listen to the community that we're working with and understand even what questions to ask, right? Because this is a real problem in general when you're trying to say, well, what are the different practices out there? Well, how do you know? Who do you ask? How do you begin this process of doing that, right? Because if we just go to the research literature and say, all right, here's 20 things that scientists have studied, we're going to miss a lot of the things that people are actually doing. And we're going to then make incorrect assumptions and have incorrect findings about what folks actually believe in and endorse and care about and see as effective or not. So we really felt that we needed to, before engaging on large-scale data collection, start by listening to the community. And this is one thing I would say as a new Spark PI that I've really admired about being part of the Spark community, is that it's clear that Spark, while it has a number of core, really important core research questions, seems to constantly be thinking about this question of, what does the community really care about and what do they say is really happening? So the way that we did this, the way that we kind of followed this pipeline, is we started off, first of all, with the literature, because you got to start somewhere. And we worked to identify all psychosocial and behavioral intervention practices represented in the research literature by a systematic review across approaches. So meaning across disciplines and across specific intervention practices. So we tried to do a sort of big, kind of capacious a review as we could. We also looked across those 3 presenting concern areas: social difficulties, anxiety, and also across populations. So meaning across the spectrum in terms of language and cognitive function. So not just limited to folks who are more verbally able or who have higher adaptive functioning scores, or folks who don't, right? We really tried to say, let's cast a very wide net. Then we conducted what's called a Delphi poll. And I'm going to tell you a little bit more about that in a second. But basically, this is a methodology for reaching out into the community and asking for members of a given community, expert stakeholders, to give you feedback on what you've asked them about and to tell you what you're missing. And I think that this is really an important step, right? So rather than just saying, all right, we reviewed the literature, let's ask a bunch of experts if we did a good job. We reviewed the literature and then used this methodology to say, look, here are the things that we found. What else would you add? What else is really important? What are the things that we need to make sure that we're considering? Or did we misrepresent this information? Did we do it in a way that is importantly accessible, translatable, and understandable to folks regardless of their discipline? And then finally, we then took that information and we engaged a large-scale survey using a national survey research company called PSRAI to ascertain the types of intervention practices being delivered in the US to folks in usual care settings. Importantly, I should share with you, I say in the US, and certainly this is, to my knowledge, the largest such study done nationally to date and broadest geographically, but we did not cover the whole US. We had 5 core regions. We had the Philadelphia region, Long Island, New York, greater Chicagoland area, and San Diego. And participants for both rounds of the study were recruited from within a 150-mile radius of each of these areas. So as I mentioned, the first thing we did after the literature review was this Delphi poll study, first authored by Connor Kearns in 2019. We would call this kind of a Rosetta Stone study. So let me talk to you a little bit about how a Delphi study is done, because I think it's valuable. A Delphi study is a method at getting at consensus meaning saying, how do we try to get to agreement across a lot of different people who are stakeholders in the same thing, but coming at it with different perspectives. One way to do it, as Dr. Cohn, who's one of our site PIs and really kind of led the charge in helping us to integrate this methodology, she said, look, you know, in the best case scenario, in one sense, what you would do is you would take all the people who you think whose opinion you want to ask, and lock them in a room together, take the key away, and say, you can't leave until you agree on stuff. You'd probably get consensus eventually, but there's some real ethical and logistical problems to doing that. And so this is not something that we do in most cases. Instead, what we do is we use a Delphi approach, where we essentially take a number of items, in this case, all of the practices that we identified in round one, or we identified via the literature review. And we asked 66 experts about them. And we said, basically, is this something that you're familiar with? Is this something that you use? Is this something that you think that you see other people in your community using? Is this something you think is effective? And then what you do, so first of all, just when we say experts, right? So this is the demographics of the experts who we surveyed in this round. And these are the different disciplines they represented. All of them had to have had at least 5 years of experience working in the field, and had to work at least 50% of the time with folks on the spectrum, and had to have served at least 50 individuals on the spectrum over the last 5 years. So when we say expert, we mean really practitioners who work with folks with autism for a living. We surveyed them about a bunch of practices, which I'm going to tell you about in a second. And then we asked them, importantly, when we would present a given practice, let's say the practice, could be something that is endorsed in the literature, like shaping behavior, or doing a lunch, doing a social group, as well as things that we sort of found that aren't necessarily endorsed but are still out there. So, for instance, one that came up a lot is use of song. Now, of course, there's some wonderful research that's gone on in the last few years about music and autism and ways of facilitating connection even through music, but sort of integrating use of song isn't a recognized sort of evidence-based practice in existing literature, but it's a thing that nonetheless people talked about. So we wanted to ask our practitioners, is this a thing you use? Is this a thing that you think is useful? Is it a thing that you think other people use and might think is useful? And then we solicited feedback from them about, are there any things we missed? Is there any things that we addressed incorrectly? And then we fed that back to them in an additional round to basically get the feedback on if they felt that this was ultimately effective. And then we looked at what their consensus or agreement was. And this is the SES of the folks that the demographics of the folks that they treated. Note mostly it's all, as I said, school age kids, relatively diverse groups, racially and ethnically in terms of who they serve, relative diversity in terms of whether they treat folks with intellectual disability, and relatively diverse in terms of SES and in terms of who they treat. And so what we found then is, after 2 rounds, we found 32 strategies total that people endorsed across all of the disciplines as being things they use to treat anxiety, 33 that they use to treat externalizing challenges, and 36 to treat social challenges. And there was a set, for example, that they agreed on, over 75% agreed regarding the fact that there were these things being useful, commonly used, and having evidence, having empirical support. So, for instance, for anxiety, this included things like relaxation, cognitive restructuring, and visual tools. For externalizing problems, things like functional behavioral analysis, also using visual tools, positive reinforcement. And social challenges, things like behavioral rehearsal, modeling, and again, visual tools. They also was a set where it was a set of items. I'm not going to go through every single one at the moment, although we can certainly come back. But that they thought were useful, but they didn't necessarily agree were evidence-based, right? So some things that people said, look, I use this, but I'm not sure that there's been research on it. So again, this could be an area that researchers like myself could focus on and say, all right, are these things that folks that are helpful that we need to do a better job of looking at. And then finally, there were also sets of items that they either thought were useful but didn't have agreement about the evidence base, useful but limited agreement in terms of whether or not other people use them, whether people are really using them, and then finally, not useful at all. So for example, people found that timeout is not a use. People agreed that using timeout for anxiety or social challenges was not a useful approach, even though it's one that folks maybe saw happening in the community. So from this project, we learned that there are in fact practices that experts across disciplines agree on. Remember, thus far for the Delphi, we're only talking about the 66 experts. This is not the broader sample yet. This is us kind of establishing this Rosetta Stone of common language, right? Common language that we can use to say, this is what this practice is. Do you see it? Which is really important, because we can communicate with each other. What we learn from this is that we can actually identify practices that across all of the disciplines that I listed, folks can at least say they can recognize what it is. They may not think it's useful. They may not think it's something that they've ever seen anyone do, but we can describe it in ways that a speech pathologist or a nurse or a special educator or a psychologist or even an MD can understand. We can, in terms of usefulness and common research supported, folks found that anxiety, relaxation, and things like this were most both widely used and useful. That in terms of externalizing positive reinforcement and related behavioral strategies were most useful and commonly used. And for social challenges, shaping and imitation and rehearsal and things like this. In terms of what was not useful, as I mentioned before, interestingly, folks identified that timeout, experts said that timeout is not useful, and they've agreed pretty strongly on that, despite the fact that some of them said, yes, I see people doing this. So importantly, this provided us a foundation for examining what others, both experts and non-experts, are doing, right? So now that we've heard from our experts about this, what are folks actually doing for real? So this led ultimately to the UCAS. So we started off, again, really butchering this metaphor to surveying the landscape by laying the foundation, trying to lay a foundation for starting to understand what practices are really happening. So thanks to the Delphi, we identified 55 transdisciplinary practices, 55 practices that across all of the disciplines, folks could tell us, yes, I understand what this is. You can tell me about it and I can at least make sense of what you're telling me. And I've seen people do it, or at least I have a familiarity with somebody doing it. And then we went out to the community and we asked a number of questions, but for this part, I'm going to tell you about the two key things we asked, which is, one, is it familiar when I ask you about this practice? And two, do you use it? So familiarity and use. That was the kind of core to this project. In fact, the way that we administered the Delphi is we would actually ask for each practice, is it familiar? And if they said no, we wouldn't ask them anything else. And if they said yes, we asked questions about use and empirical support. For example, we might have a strategy like behavioral rehearsal or role playing, or choice making and providing choices, or cognitive restructuring, or using coping skills or self-talk, or using computerized games and activities that require nonverbal skills, or differential reinforcement, or embedding special interests inside social interactions, right? So these are all things that, as I'm describing them to you, those of you who are practitioners or even family members might think, oh yeah, those sound familiar, I've heard of that, or I even associate it with one name brand intervention approach or not, but we didn't approach it in that way. We really tried to break it down really granularly and just saying this practice itself, regardless of what you call it, regardless of what label you slap on it, regardless of where you get trained in it or how you get trained in it, this thing, what do you do? It could also, again, include things that are, again, not necessarily explicitly behavioral, like, and in fact, many of them aren't, like, exercise, sensory breaks, physical activities, games that non-computerized games that require use of nonverbal skills. Again, use of song, was assigning homework, or imitation, right? So that's sort of the kinds of strategies we're talking about. And in this study, we nationally then across those different sites recruited 674 providers, again, nationally. In fact, we actually had 701 participants, but we ended up using a tool that we developed as part of this to identify what we called fraudsters, which were basically folks who seemed to be participating in the study, just so they could get a gift card. And so we were able to exclude them using that methodology. So we had 674 kind of verified real people who are practitioners. And they completed a questionnaire of familiarity with and use of the practices that I just described. We also asked them to provide information about themselves, their own kind of professional demographics, as well as where they work and the demographics of the folks who they serve. So in the full UCAS, we had about 13% psychologists, 17% behavior analysts, 9% medical doctors, 29% allied health professionals, which includes things like OT, PT, speech, etc. 16% others, so that includes things like educational providers, like school counselors, special education, even special education administrators, and then 14.8% who endorse multiple of these. So again, ultimately, when we ran our analyses, we broke them down kind of in this way based on kind of some statistical reasons I won't get into right now. And we looked at basically differences in familiarity and use based on provider categories. So which category they're in, their own educational attainment. So are they somebody who had not yet completed a 4-year degree, MA or doctoral? The number of years working with folks on the spectrum. The treatment setting, do they work in one setting or multiple different settings? Do they work with folks with co-occurring intellectual disability or not, and how much? And do they work with folks with particularly high or low socioeconomic status? And so just this past summer, actually, we published the familiarity paper, which kind of looks across all of the different disciplines, again, not broken down by what it is that they're trying to treat or address, just looking kind of broadly at what people are doing. And we looked, what we did is we used a kind of fancy statistical technique that I will not get into right now, but basically to identify practice sets, essentially packages of things that people do together. So meaning if somebody says, I'm familiar with this thing, I'm also familiar with these other things. And the reason for that is because, in reality, even though we can break things down in the way that I described, realistically, very few people are just doing imitation or just doing, meditation or just doing mindfulness or just doing modeling and imitation, right? In fact, it might be kind of strange as a provider to say, well, all I do is I will sit here and I will imitate your child. That's it, nothing else. I won't talk to them. I won't assign any homework. I won't try to build a relationship. I won't work with you as the parent. I won't do any kind of thing. I'll just sit here and imitate, right? It would be kind of odd to just do one strategy. So we wanted to understand, though, what are the packages of strategies then that people are kind of using in the world? Because if we're going to make any kind of predictions about them, if we're going to try to address them, we're going to try to look at their evidence base, we need to sort of look at how people are really behaving when they're trying to help folks on the spectrum. And so for familiarity, we identified 3 what we call practice sets or kind of packages of strategies. The first is environmental modifications or antecedents. So there were 9 strategies, including things like choice making and providing choices, environmental structuring, and embedding special interests in social interaction. In fact, this was sort of the big one that people were most familiar with. right? People across disciplines, across all of the sites in the United States, across things that they say that they're trying to treat or address. The second was behavioral analytic strategies. So there are 18 strategies endorsed, including differential reinforcement, extinction, and shaping. But again, these are things that when we describe them, again, we didn't just say what's extinction, right? We would say, let me describe what this actual practice looks like to you, so that somebody who's not a behaviorist, for instance, can say, yeah, I never knew it was called that, but yes, I am familiar with that. And then finally, cognitive strategies. There were 5, including self-awareness, bodily response, psychoeducation, and psychoeducation, things like that. And what we found here is differences in familiarity with these strategies, kind of according to each of these different different kind of characteristics of the clinician and the people who they treat. In particularly, one thing we found is that overall, I'm going to break this down for you in a minute, so don't worry, you don't need to process this whole table on your own. We found that overall, actually, medical providers tended to be less familiar than all other disciplines in terms of any of the strategies on average. We also found that, interestingly, that the people with the most and the least experience tended to be report being more familiar than those with sort of the middle levels of experience. And then also those with high and or low, who treat high and or low socioeconomic status, kind of primarily tended to be more familiar than others. So, overall, what have we found, right? Just to sort of synthesize that table a little bit, so you don't have to walk you through all the little bits of it, is that those with a doctorate on average seem to be most familiar, we report being most familiar, but interestingly, those with a medical degree in particular seem to be less familiar overall, but particularly less familiar with behavioral and more familiar with cognitive strategies, which is a bit of a surprise. We found in terms of experience that those with more experience tended to be more familiar with behavioral and sort of setting modification, environmental modification approaches. But interestingly, those with fewer years of experience were actually more familiar with cognitive approaches. In terms of treating those with intellectual disability, those with those treats who reported treating folks with ID reported being most familiar with behavioral strategies, which might not be a surprise to some of you, but actually reported only sort of moderate levels of familiarity with setting and cognitive focused approaches. And finally, in terms of socioeconomic status, we saw kind of a mix in terms of this. So what about use? So we then ran the exact same procedure that I'm talking about, but looking at use, meaning asking people not just packages or sets of things that they're familiar with, but rather what are things that you actually do? What are these 674 providers across different disciplines when they're working with folks on the spectrum? What are the things that they're actually using to try to help? We actually found 4 practice sets here. The first one is what we would call consequence-based strategies. There were 8 of them, including things like positive reinforcement and token economy, basically kind of giving people reinforcement, after certain things that they wanted to maybe support. The second is CBT, or more therapeutic strategies. So there are 12 of them, including things like self-awareness of their own bodily response or psychoeducation, but kind of teaching folks kind of in ways that we might associate more with traditional psychotherapy or contemporary psychotherapy. And then antecedent-based strategies. So these are strategies to focus on kind of before something happens, whether it's again, a challenging behavior, a social difficulty, or anxiety that folks use to kind of set the stage or the context. So this could be things like embedding special interests in social interactions, trying to figure out, all right, you're gonna go play with a peer. How do we make sure that the things that we are using or playing with are things that are motivating to the individual child, as well as visual supports or tools, again, to kind of make the setting or environment more accessible. And then finally, sort of direct teaching type approaches. So these are things like shaping, stimulus control. Some people in our group call these sort of more advanced behavioral strategies, for lack of a better term. In terms of who's actually using these strategies, right, so the different ones. So we found for the consequence-based approach, so again, that's that first set, right? We found that those with behavioral backgrounds and less than 4-year degrees and sort of less time working with folks on the spectrum, fewer years, as well as those who treated intellectual disability frequently, all reported higher use of consequence-based strategies. In terms of therapeutic strategies, we found again that those who reported behavioral background, as well as those with 4 years in MA and master's degrees, as well as those with high socioeconomic status, they all reported more use of CBT therapeutic strategies. In terms of antecedent-based approaches, is again kind of preparing the environment kind of approaches. We found again that folks with behavioral and other a few other disciplines seem to do the most. Interestingly, we found that those with a doctorate tended to report using these strategies less than everybody else, as well as those with less experience, fewer years of experience in the field. And finally, in terms of teaching, we found that those treated behavioral and mental health challenges, as well as those 4 years in MA and those worked in multiple settings, did this the most. So again, to kind of synthesize that for you, we found that interestingly, those who indicated having a behavioral background reported using all of the strategies, essentially more than everybody else. Those with less education reported more consequence-based approaches rather than kind of antecedent or setting-based approaches. Those with more education actually reported less use of these teaching-based approaches, which I think is sort of important for our understanding and unpacking. And importantly, having more experience with folks on the spectrum does not necessarily mean you're using these strategies more. I mean, we actually found that those with more experience use less consequence-based approaches and more antecedents-based approaches. We also found that those who worked with folks with intellectual disability used more consequence-based approaches, which again, I think is sort of an interesting thing to think about in contrast to the experience finding. And then we found in terms of socioeconomic status, that basically those who use those CBT or therapeutic strategies, that seem to be largely not reserved for, but certainly preferentially used for those who had higher socioeconomic status, and then otherwise it was mixed. So, what are some of the things that we've learned to pull this together? We were able to identify some transdisciplinary practice sets, basically things that people kind of do in bunches together when they're both thinking about supporting those on the spectrum. For familiarity, we learned that setting and learning approaches, behavioral analytic and cognitive approaches tended to be the practice sets, whereas for use, we found that consequence-based approaches, CBT therapeutic approaches, antecedent-based approaches, and teaching tended to be were the things that bunched together. And I think it's important to kind of recognize, and you just pause and realize, these are not the same. These are not all exactly the same, right? So it's not just that people said, I'm familiar with these things and that's what I do. There seems to be a real distinction, a real divide between the things that people say they are familiar with and what they actually do. And I think it's important, when we think about this literature, to think about how do we unpack that, right? Is it that people are familiar with things and they say that they're not useful? Is it things that people are familiar with things, but they're not sure how to do it themselves? Or is there something else going on here? It's important to note, in general, what we found here is sort of marked gap that broadly between familiarity and use across provider types, settings, and populations. It's also important to know that years of experience is not reliably predictive of familiarity or use, right? So it's not just working with folks on the spectrum more gets you more of these different approaches, that there really do seem to be some really key divisions. And it's not just that being experienced means you know how to do all of the things, or even are choosing to do all the Interestingly, people like this guy who get to wear fancy robes and have a doctorate was associated with being more familiar, but not necessarily using strategies more. And I think that that's a really important distinction that we understand, right? That getting the more education that we have, and again, this is me, right? That I'm very very much just as guilty of this as anybody. Does not necessarily mean that we are saying that we are comfortable, able, capable, and actually using those things that we've been learned about. And ultimately, I think we're finding that these findings can provide guidance for dissemination of evidence-based practices by providing a map of the peaks and valleys of the research practice gap. Importantly as well, just zooming back for a second, talking to providers in this way can also give us other really important information about what's happening in the community. For instance, Connor Kearns put also another paper in 2019 using the UCAS data, looking at practices related to trauma screening. Basically, those were other items that were on the UCAS, where he's basically asked about various different types of trauma experiences, which we do now know are often more common among folks on the spectrum. And we're asking providers, are you actually asking about this? Are you screening for these things or not? And what we found is that, well, there is some screening happening for some things. In some ways, there's also huge gaps, which means we're probably missing some rather substantial traumatic experiences that folks on the spectrum are having. We also can look at we looked at predictors of expert familiarity. Chelsea Cooper published a paper just this past year, looking at what are the factors that actually lead to in the Delphi stage that lead to those experts saying they are familiar with strategies, as well as I mentioned, using a tool like this to identify fraudsters, folks who are kind of taking advantage of doing surveys like this. And we have some other projects as well, kind of, again, leveraging a data set like this. And I both want to share these with you because I think they're going to be important outgrowths of the UCAS project, but also I think a nice model for how we can, just like in Spark, we're sort of reaching out broadly to the community of autistic folks and their families, that reaching out to those providers and understanding what they're doing it can be really valuable for answering other really vital questions. First, we're going to be looking at use and usefulness of empirically supported strategies, and particularly how this breaks down by specific domain. Meaning, right now I just told you in general, but what about use of strategies specifically for, anxiety versus externalizing, for example. Dr. Cynthia Brown, who's a co-I on this project, has a paper coming out soon looking at provider self-reported use and usefulness of strategies for externalizing behaviors, for example. And so this is sort of digging a little bit further into that, particularly in the evidence-based domain. We can look more deeply, as Megan Breconier is going to be looking at, in terms of differences by the presence of intellectual disability or not. Crucially, Liz Cohn also is going to be presenting soon data on the genetic screening process. Again, for those of you who are in the Spark community, you are more familiar with this than most. But importantly, even at the time of this study, when we collected them, genetic screening was still a little less common than it is right now. And so understanding whether or not practitioners are even thinking about doing genetic screening is really crucial. As well as trauma screening differences by race. Kristen Walker, who works with me, is really digging deeper into that question of not just, are we screening folks in terms of their trauma experiences, but are we over or under identifying or over or under looking for those types of experiences in Black autistic children versus white or Hispanic autistic children, for example. As well as Jessica Shida, who works with Amy Drahoda, is looking at differences in practices of technology-aided interventions in more rural areas. Again, an idea that perhaps has become even more important for us to think about after living through the COVID pandemic. So we have some key then gaps and directions that we need to look into in this field. Specifically, when does familiarity lead to use? Right, being familiar with it, saying I know that a strategy exists is a start, and often a lot of the educational approaches we might use, a lot of the training approaches we might use, the first thing they're going to do is give you familiarity. I've heard of this, I know what this is. But what's the gap? How do we actually get from familiarity to use? What about usefulness, right? When does familiarity lead to, is it because people think that it's useful? Is it because people think it has empirical support? Crucially, is it because clinicians feel like it has stakeholder value, right? I can tell you there are strategies that, that I'm aware of that I can think, okay, I'm familiar with this, but I may or may not use it depending on whether or not the families and individuals who I'm working with see it as important and valuable to them and their own personal goals. That's an important gap for us to continue to look at in this field. Also, when does it not? Right? So what about the practices that folks say they're familiar with and don't endorse? Say, I would never do that. There were quite a few of them. And yet these are practices that are out there in the community. People know them enough to be familiar with them. What do we make of those and how do we address that? We also, of course, can leverage this kind of approach to look at other age groups, both younger kids as well as young adults or even older adults, and say what practices are being used in those groups, as well as other targets other than anxiety, social challenges, and externalizing. Crucially, these data were collected in UCAS before COVID. So how has the landscape of practices changed post-COVID? Dr. Allison Namias here at Stony Brook has been looking at some of those differences locally in a sample of folks who we've been working with for a while. But what about more broadly? And what do we make sense of in terms of those choices? And are they effective and valuable? Are we increasing access? Or are we missing out on practices that are really important that are not being presented? And of course, as I showed you in the map, there were lots of big gaps, white spaces. So perhaps we need an even larger follow-up study, looking at the rest of the country, the areas, that are not as well represented in the 5 regions that we looked at. Perhaps a Spark study, for instance, for providers. So, ultimately, what's our take-home message here? Well, one, as I mentioned, and I hope I've convinced you that this is a useful metaphor, to build a bridge between to bridge the practice access gap, you need to survey the landscape first. You need to know what folks are really doing. You need to address it. You need to find we can find a common language among practitioners. This is something we now have evidence that we can do. Great, really exciting. How can we better loop in families then? How do we make sure that families' voices are also being included in this question, right? What if there are practices that, practitioners say, it's useful, it's great, it's evidence-based, everyone's doing it. And folks in the community are telling us, I don't know about that. Well, we need to find a way to bridge that gap effectively as well. But again, we can't do it unless we have a good sense of what folks are really doing out there. So, it's also important to realize that what people actually do or find useful and think is evidence-based is not all the same. And that, but that identifying predictors of those things is one of the ways that we can actually target our dissemination implementation practices more effectively. And finally, and finding these things out can ultimately accelerate the dissemination of new and improved practices, right? If we can say, here's a practice that everyone says, I use it, it's great, I feel confident, it's evidence-based, and we say, wonderful, the literature supports that too, then maybe we don't need to build much of a bridge. Maybe we just need to tell people keep doing what we're doing in that area. But then we can focus our efforts out there. And ultimately, I hope I've also convinced you that community engaged participatory research and dissemination implementation research is really, really important in the broader universe of autism research. Again, many of you are involved, most of you on this Zoom are involved in Spark, and so you have good sense of of many domains of the most cutting edge autism research. I hope I've shown you another angle of such research that's really important, that can listen to the voices of folks on the spectrum and their families and their providers, and use that to help us make sure we're asking the right questions when we're doing research, not just the questions that we as researchers think are interesting. And it can also help open the doors to other important questions, ones that we haven't thought about, but need to. So ultimately, I just want to thank the UCAS PI team, who I mentioned earlier, as well as the many other UCAS authors, these are all co-authors on some of the papers I cited today, as well as the 750 or so Delphi and UCAS participants, the funders of this project, and of course, I want to thank Safari, in particular the Spark group, for hosting this webinar and giving me a chance to share this work with you. Thank you all for your time. I have a few minutes for questions.
Great. Thank you so much, Dr. Lerner. And yes, we have a couple minutes for questions. So we won't waste any time. We'll jump right into those. So one question that came in was, did you find that practitioners were familiar with any social, emotional, developmental interventions for children or adolescents? Dr. Lerner, are you still there? Oh,
I am. I disappeared for a minute.
that's okay. Did you hear the question, or do you need me to repeat?
I heard you say one question that came in, and then it was it. That was it.
Sure. Yeah. So it was, did you find that practitioners were familiar with any social, emotional, developmental interventions for children or adolescents?
Yeah. So the answer is yes and no. So I think the interesting thing about this study was that, we didn't really define them in that way. We just asked about the specific practices. So there are certain things that are part of social, emotional, developmental interventions, like following the child's lead, creating opportunities for social bids and elaborating on those social bids, right? These are some of the kind of hallmark features of those types of interventions. And we did find, we did see them, right? They were endorsed as specific strategies, and there was kind of differential familiarity with them. And one thing that we can and will do is maybe try to almost reassemble some packages like that and say, all right, do they actually even hang together, right? The fascinating thing to me is maybe there are things that we call social emotional developmental interventions, or NDBIs, naturalistic developmental behavioral interventions, right? This is a really important growth of the field. Well, we should ask, I think it's important to use a tool like this to ask practitioners, are they even doing those things? Without putting a label on it, we just name a bunch of strategies. Are those things even hanging together? Or maybe folks are only doing one or two of them along with a bunch of other things instead.
Great. And then what about medical interventions such as the use of medication? Was that recommended by any of the practitioners?
Yeah, so we did focus on kind of non-pharmacological interventions. The idea being that for this, even though we obviously we hadn't medical providers here, the idea was, what are things that in theory anybody could endorse doing, right? A person who's a speech pathologist, for instance, might endorse if I describe certain behavioral or cognitive strategies without putting a label on them, right? Without saying, oh, this is what a psychologist does. I just say, let me just describe this to you. I might describe to them, priming, and they might say, yeah, actually I do that. I hadn't thought about it. And so that can happen across all of the disciplines for the strategies that we looked at. But for medication, you hopefully, I really hope this is true. I know, you can't accidentally prescribe somebody a medication, or you can't, describe medication and be like, oh yeah, I prescribed that. I hadn't thought about it.
Right, and I guess we have time for one more quick question here.
Sure.
So what were you talked about the regions that were used, those 5 key regions, but then delving a little deeper, what were the racial groups included in some of these studies?
Yes, excellent, really excellent question. So one thing, I am rather proud of in our group is well, it was not as diverse as it could possibly be. We did have fairly high levels of racial diversity in terms of who the folks are treating. We didn't look at the race of the practitioners themselves, but we did have a fairly good distribution. I'm actually trying to find our groups. Yeah, so across, white, Black, or African American, Hispanic, Latino, Asian, Native, and we actually even had a good number of practitioners who said they primarily treat Native American or Hawaiian or Pacific Islander groups, of which to date there's extraordinarily little research on treatment of those groups. In fact, Kristen Walker, who I mentioned earlier, is actually going to be putting out a paper soon, kind of looking at those differences by that group.